Assalamu alaikum everyone, and welcome to the Health and Fitness Show. Today with your host, me, Lamisa. I hope you all are having a wonderful evening. And I'll just introduce our topic, I guess. So today's topic is understanding common paediatric conditions. And we're very lucky as we've got a very special guest joining us today, Dr Aamna Ali, who is a Paediatric Registrar at our local hospital. Do you want to say hi to everyone?
Hello, hi. Thank you very much, Lamisa, for a very kind introduction.
No worries. Thank you so much for coming.
My pleasure.
And I guess we'll just get straight into it. So I feel like pediatrics is, an area of medicine that everyone who is a parent essentially encounters. And it is a very important topic because there's so many things I feel like with medical terms that is unclear even to us medical professionals. So I can imagine how difficult it may be with people who don't have that medical background. So hopefully with today's show, we're going to try and break down a lot of these common conditions that parents might find that their children have, and hopefully just work a bit more to providing that information to everyone out there. But I guess before we begin, do you want to kindly tell our listeners about yourself and your career in paediatrics, kind of touching on why you chose paediatrics and what you find about the medical specialty that really drew you in?
So my name is Aamna, and I'm one of the Paediatric Registrar, and I'm working in Luton and Dunstable Hospital at the moment. So why I chose pediatrics? So it's basically a series of events that led me to my destiny of being a pediatrician. So from the very start, when I was in medical school, I wanted to kind of do medicine. And then coming to our final years when you do your house jobs. So I found my interest in pediatrics. I really enjoyed my training in the pediatrics. And then soon afterwards, I got married. I had a kid of my own. So my little girl, she was born quite early. She was preterm baby, born at 26 weeks. And she received a period of neonatal ICU care. So, and at that point, I just think I got inspired by all the medical team who looked after them really well. So I think, so those were the series of events that led me to apply for pediatric training program. And then here I am.
And how are you finding it so far?
So it's very nice. I really enjoyed my work, every day. I think every day is amazing, looking after sick children. And then the good thing about the pediatrics and our patient population is that a little input that you give towards towards kind of looking after them, and they will give you the results straight away. And
Which
they
is
get better.
Nice to see,
Exactly. So that's very rewarding, I would say.
Yeah. Well, that's great. And obviously I've worked with you. Amina is absolutely amazing at work when you see her in action.
Yeah, I can say the same things about you, Lamisa.
Oh, I appreciate that. And just so our listeners get a bit more of an understanding into paediatrics, what does the field of paediatrics involve? And, from what age groups perhaps as well?
Okay. So, basically we practice medicine, so we are physicians, and pediatrics basically involves around giving the care to a baby when they're born, or in fact, some will say before even the babies are born. So some part of the neonatal medicine, you kind of get involved before with the pregnant mums. So from there onwards to the age of 16 years, so we are involved in looking after children, providing our input and just kind of looking after generally everything, so yeah.
Very nice. Okay, so that's basically an intro into Amina and an intro into today's show in terms of what paediatrics is. And then we're going to be going through various conditions today and hopefully trying to break them down a bit more. Do you want to run through kind of which conditions we'll kind of be discussing today and things that we'll be touching upon?
Sure. So I think the most common thing that most of the time that all parents have kind of worried about is the respiratory illnesses. So I will be talking about bronchiolitis, viral wheeze, and then asthma. And then moving on for further, we'll just think about like a common childhood illnesses, and we'll talk a little bit about that. and then,
Yeah, exactly. Okay, so I know you touched upon the fact that we will be discussing asthma, so I'll come to asthma first. So do you want to let our listeners know, kind of explaining a bit more about what asthma actually is?
Yes.
Kind of a bit about the physiology maybe as well, because I
Yes.
feel like that always helps towards understanding.
Definitely. So asthma basically is a kind of inflammatory process which is going on into your airways and into your small airways.
Okay.
So which means that your bronchi, which are inside the lungs. So asthma basically is, we tend to say in medical terms, it's like a triad. Three things make the asthma. So what is going on when a child is having an acute asthmatic episode is a bronchoconstriction. So basically narrowing of those small airways.
Yeah.
Then you're having the mucus plugging. So there is the lining of the airways. It's very rich in kind of secreting this kind of a mucus bit, and that mucus can lead to the plugging and the blockage. So narrowing has happened, blockages happen, and then there is inflammation. So those three things lead to the asthma.
Okay.
Now coming to the triggers, now anything can be trigger for the asthma, from the cold weather, to the pollens, dust mite, or illnesses. So if your child is kind of going through any kind of a viral illness, especially the respiratory viruses, can lead to the flare-up of this triad, and that leads to an acute asthmatic episode.
Okay. And what kind of happens during an acute asthmatic episode? What are the types of signs or symptoms that we might see?
Yeah, so I think the most important is that if you, in asthma, you would know, our parents of a asthmatic child would know that they have got asthma, and the signs and symptoms, most of the time they know already, which will be that you'll be having difficulty in breathing. So that will be the first sign. So the signs that we tend to tell them is that your child is putting an extra effort in their breathing, and they will be using their accessory muscles. So you will say, just like a normal breath that we take, they will be using the muscles around their face, neck, and their chest. So you'll be noticing a bit of a nasal flaring, a bit of a tracheal tug, and a bit of a subcostal, means between the chest and underneath the ribs, they will be having some recessions. So those are the signs that your child is actually putting really effort into the breathing. And the second signs that obviously none of the parent would want to see, but that would be a kind of a bluish episode. So you'll be turning around blue, really gasping for air.
Yeah.
So, and the third, obviously, signs which, again, we don't want to see, because we are expecting that your child would definitely have help prior to that.
Sure.
Would be basically when they are not able to kind of speak, and they have gone basically silent.
Okay.
So, yeah.
And at what point would you say it would be appropriate for people to essentially call help or maybe seek further medical advice?
Yes. So all the parents of the child who has got asthma, normally we tend to kind of educate them on these signs and symptoms. So there are things that they can treat at home. So let's say if a child who has got known asthma and who's now started to kind of work a bit hard with their breathing, then we tell them to kind of give them their inhalers at appropriate time, and we give them the quantity of the inhalers that this child should be having.
Sure.
So I think it's just, if you are coming to the point where you are giving frequently inhalers and the child is not getting better, they are still struggling with the breathing, I think you just need to call for help. Call 111 or take them to their GP, nearest GP, or bring them to the A&E, because at that time a health professional needs to assess them and give the appropriate medications.
Yeah. Definitely. I feel like that was a very good kind of overview of asthma. Kind of what age group do we typically see that asthma arises in children, would you say?
Right. So the diagnosis of asthma, we tend to kind of make mostly after the age of 5 years. So your child can have the similar sort of phenomena, and we'll talk about it in other kind of scenarios where they're having the viral-induced wheeze, which commonly happen between the age of 1 to 5 years.
I see.
Or the similar sort of pattern of triad of things have been happening in the chest of a little ones, less than 1 year old, but we tend to name as bronchiolitis.
Okay.
So asthma is basically the name diagnosis for the respiratory problem for children above 5 years of age.
Okay.
And it basically involves you not just having these acute episodes, but intermittent symptoms as well.
Okay.
So let's say if a child is having the problems with the cough or difficulty in breathing after the exercise, or they are having the nighttime symptoms. So the asthma the symptoms of asthma tends to kind of get worse during the nighttime or early in the morning. So those are the intermittent symptoms that make the diagnosis of asthma in above 5 years old.
Got it. Okay. So that was great. And I know you touched on it. So under 5 years old, we're thinking more about a viral wheeze, and maybe under 1, we're thinking about bronchiolitis.
Yes.
So I guess we'll start off with the viral wheeze. If you were to explain a bit more about it, you said it was similar to asthma. Do you want to expand a bit on it?
So yes, so why it's similar to asthma, but we don't label it as asthma. The reason being, in 1 to 5 years old, the body is basically making up these white cells to it's indiscriminately making these white cells as a kind of a defense mechanism to any sort of a infection.
Okay.
So let's say if they have to have like a viral upper respiratory tract infection secondary to any of the viral bugs, most commonly RSV or influenza A and B or COVID, they will tend to have this kind of a inflammatory response goes around their chest. But it's one-off episode, or they might have it with every season or with every kind of viral infection, but there will not be intermittent symptoms. Okay. This child is not going to have the exercise problems as well, and there is no usually background family history of allergens. In those sort of cases, the management this is the same, So these children, with the first episode, you definitely need to bring them to the hospital. So you would know your child is working hard with the breathing, all the signs and symptoms of nasal flaring, tracheal tug, or the recessions are coming in. This child needs to be seen by a health professional. Yeah. And then we might start your child on some inhalers as well. And we'll just give parents a strong advice, so just in case if this happens again, you can either manage it at home. But if you have to give too frequent and too much of their inhaler, then it means that they need to come to the hospital and they need to be seen.
Yeah, and that obviously goes off of a case-by-case basis based on how they've been reviewed at hospital. So viral wheeze, common risk factors include kind of viral infections essentially in children. Definitely. And then bronchiolitis, is it pretty much similar, just kids under 1, or is there anything else that's slightly different with bronchiolitis?
No, so bronchiolitis again is a kind of a similar sort of thing, but it's going on, it's a diagnosis of less than 1 year old. And again, for the parents, it's very important to especially these children less than 1 year old, their immune system is not very strongly developed. Yeah. So if a viral infection start coming down from your nose, from your mouth to your chest, just need to make sure that any kind of signs of increased work or breathing, this child needs to come to the hospital. The other thing, a very important thing I would like to say is that fluids. So all these children in any population, so either less than 1 year old, 1 to 5 years old, or above 5 years old, with any sort of infections, illnesses, their fluid intake will go down. Yeah. But it's very important for parents to monitor for the hydration status. Yeah. So just making sure they are having plenty of wet nappies, or they are going to the loo, regularly. Yeah. And then just not getting dry, they are not getting the dry mouth, Sometimes in babies, although it is a kind of extreme of the dehydration when they're crying and there's no tears coming through, especially we tend to say it for children who are less than 1 year old or so. So those are the two signs. So if your child is working hard or their fluid intake is going down, it means that they need to be in the hospital because they need all this kind of a supportive management to help them recover. Yeah. So that's something to look out for. Yes. I think it's something I definitely learned via doing the paediatric rotation. A lot of the management that we do is we do try and support babies to come out of this little period with, things like fluids and giving them help with their airways. That's great. Okay. So that covers our respiratory illnesses, common things that we may see. I guess now what I'm going to do is move us on to talking about another topic that's pretty common with children is vaccination. So as we know, all babies have to go through in the UK the vaccination schedule. So in terms of just beginning to explain the concept of vaccinations, how do vaccinations work and what is the theory behind doing it? Yes, definitely. So the vaccines are basically designed because people in the back in days were noticing that all these kind of illnesses like smallpox, tetanus or polio can be prevented by just giving, either the weakened form of the same bug or just taking some like bits and pieces of this bug, like a protein, and then what I'm trying to say is that some of these bugs are made of the proteins, like the outer shells are made of proteins. So just kind of taking this protein out of this bug and then giving it to the healthy individuals will actually make the healthy individual's immune system to work hard against this foreign kind of a antigen and then boost up the immune response. And then in case if this healthy individuals whose immune system is already prepared to fight with this infection will then actually get the infection, will be able to get rid of this infection straight away. Right. So it's better, it's more like a preventive medicine rather than curing of the medicine. And I think it's a very kind of a innovative sort of thing that had happened back in the mid of 19th or 20th century. I think, and which has led to which has basically increased the duration of the lifespan, to the human race as we of now. Exactly. So the vaccinations basically essentially work in that way. So we have got either live vaccines or we have got live attenuated vaccines, which means that there's a live bug that will be given, but it is basically weakened. And then there will be the vaccines where they will give you the part of the bacteria or the synthetic formulation in which your body is basically imagining it as a foreign antigen and trying to kind of boost up the immune response. So it's essentially preparing your immune system for the worst.
Exactly. In case it comes in contact, it's ready to go, basically.
Exactly.
Okay. And in terms of why children should be vaccinated, obviously the initial benefit is the fact that their immune system is prepared. But in terms of kind of herd immunity and things like that, how does it help from that perspective?
Yes, so basically it's like an umbrella protection. It's the Oxford School of Medical Sciences have put it up in a very kind of a nice way. So if, let's say, you have got every person is kind of getting vaccinated, they are opening up an umbrella. Okay. So when it rains, so imagine if there's a disease and it's pouring down like a rain on you. If everybody has got their umbrella open, so if there are little babies, little children, in between, or there are elderly people, they will, even if their umbrellas are not open, they will get protected.
They will get some shade. Yeah, that makes sense.
So that's how the phenomenon of the herd immunity is in the community. So if everyone gets vaccinated against these kind of a very notorious or lethal diseases like diphtheria, pertussis, polio, tetanus, especially the people who are vulnerable in our community, which will be elderly, people who are immunocompromised, going through the chemotherapy, or small babies, they will tend to get protected because those diseases will not get the chance to get to those to that population.
Okay, that makes sense, because if no one has it, then how can it get to them? Yeah, fair. Okay, that's great. And just regarding some kind of common misconceptions regarding vaccines, how can we kind of dispel those? And then where can patients get more information regarding vaccinations, should they want to read up a bit more about it?
Definitely. So basically, NHS is a very good kind of a resource itself. So anybody who has got any sort of questions, they can go on there and onto the website, and then they can kind of get more the information that you want to take it, and then speak to your kind of a GPs. They are there. So if you have any particular concerns, then speak to the GP, and they will try to, even if they haven't got that information on the first hand, they can get the information from the source, and then they can give you the right information. So I will definitely encourage people to speak to, the health professionals about it. So the common myths around the vaccination. So first of the common myths about the vaccination is kind of that there are kind of other adjuvants that can be present inside the vaccinations, that can let to people think that apart from getting the good benefits of the vaccine, they are getting other things which are not necessary. But unfortunately, in how the how the vaccinations have been prepared, they take these adjuvants into the place to make the vaccinations more potent. So things like aluminium, scoline, formaldehyde to kill the bug itself in most of the live attenuated vaccines. But the thinking behind is that even if you have this, it's very small. The particle number is very small.
Okay.
And if you think about it, in this 21st century, we are getting exposed to a lot of things anyway. So like aluminium will be present in the formula milks of the baby, in a very small amount. So it's not going to harm you, but it's present there. Nobody can deny it. So the same happens with the vaccinations as well. And there will be things like formaldehyde. Again, with the formaldehyde, once the bug has been killed, the effect of it is very minimal, in most of the live attenuated vaccines. And there will be some. So the next thing the parents are tend to kind of worry about when they have come to me will be things like allergies. Mm-hmm. So their child had some sort of a vaccination and they got allergic reaction to it.
Fine.
So most of the time, yes, there are some vaccines which take like the egg protein to kind of formulate. Some of the flu vaccines do.
Yeah.
And some of the MMR vaccinations, they tend to have a part of their egg albumin that they tend to use.
Okay.
I think if it is a kind of a severe anaphylactic reaction, so definitely you need to speak to your health professional, and we need to get an alternative for that.
I see.
But if it is not an anaphylactic reaction, and if it is some sort of a minor rash or then there's sort of cases under the guidance of the health professional, we can kind of rethink about giving your child the vaccination, because I think at the end of the day, it's the risks versus benefits of it.
Yeah.
But most of the time in a general population, you won't get the sort of allergic reactions. And same, some of the medications, some of the vaccinations, they tend to use these antibiotics. They don't use normally the penicillin, but they tend to use some neomycin, like a part of the neomycin.
Okay.
But again, the allergic reactions to it is minimal, So again, with the first dose of vaccination, your child will be monitored. You will be given all the safety netting sort of advice. What are the things to exactly. And if you're worried about it, just bring your child back. But I think again, the benefits of these vaccinations are far, far, far more as compared to any of the side effects that we're thinking of. And we have got a way to mitigate those side effects as well. So please speak to a health professional if you are worried about anything in particular.
Definitely.
The third thing I would like, a very interesting kind of a thing that was brought into my attention quite recently, that parents are getting worried about neurodivergent conditions with their vaccinations. There have been research papers that have been published which haven't associated any sort of a vaccination, with the neurodivergency. I mean, it's a vast domain and still looked at, but it's not associated with the vaccinations as of yet. So parents don't need to worry about it. I think it's better to kind of get your child vaccinated and prevent them from the preventable diseases than to kind of worry about the neurodivergent conditions later in the life. So, yeah.
Okay, yeah. And I guess our main advice, as you said earlier, would always be if you have any questions or there's anything that you're worried about, always go and speak to the healthcare professional that is obviously looking after you and your child. And they're there to answer your questions.
Definitely.
I feel like a lot of the public that I come in contact with, they're kind of scared or maybe feel somewhat, embarrassed maybe to ask questions. But the whole point of, healthcare professionals, we're here for the general public's health. We're here to advocate for them. So it's always important if you have any questions regarding anything in healthcare, whether it be vaccinations or whether it be, you're at the hospital and you don't understand something, it's always fair to ask whatever's on your mind.
Definitely. Yeah. I think one of the things that I kind of forgot to mention, most of the people, specifically from Muslim community and some of the Jewish community, have got the concerns about some of the vaccines are formulated with the bovine kind of a gelatin. But let's say, for example, the flu vaccine, the intranasal one has got the bovine, but the intramuscular one, which is given into the muscle, hasn't got it. No. So there are alternatives. That's what I'm trying to say. And then you can speak to your religious communities as well, the scholar of the religious community, and take their advice and support. I think most of the Muslim communities, the religious scholars have given the permission because the amount of the gelatin they have used is small. Yeah. But I can understand the cultural things can come into play, but there are alternatives.
Yeah, definitely.
So it's just you speaking out, just asking for an alternative, and we are there to support you.
Exactly. Advocating for yourself.
Yes.
But yeah, that's great. I mean, that kind of brings us to the end of the first half of the show. So that was very, very insightful. Thank you so much for kind of going into those topics. And hopefully our listeners will find it very, very useful. I just want to let everyone know who's listening today. We are on Facebook Live, even though the show is not live. It's pre-recorded. But yeah, you're listening to the Health and Fitness Show on Inspire 105.1 FM. We do hope that you'll be joining us after the break as well, where we'll be continuing to discuss kind of common paediatric conditions that you might face with our guest today, Dr Aamna Ali. But yeah, just as a quick disclaimer, all of the information is meant just for informative kind of purposes. If you do have any kind of direct medical inquiries that you want to ask, we would always advise you to go to your actual healthcare provider, be that your GP or whoever you have as your registered clinician. But yeah, thank you all so much for listening, and inshallah we will see you after the break. Assalamu alaikum wa rahmatullahi wa barakatuh.
Find Luton Prayer and Masjid Jamaat times at inspirefm.org.
Assalamu alaikum everyone, and welcome back to the Health and Fitness Show. Before the break, we were discussing kind of common paediatric conditions. We kind of touched a bit about asthma, viral wheeze, and we talked a bit about vaccinations as well. So in this second half, we're going to delve deeper into a few other conditions that you might notice in your child's kind of upbringing. We've got our special guest today, Dr Aamna Ali, who is a registrar at Luton Dunstable Hospital in Paediatrics. So thank you again so much for joining us.
My pleasure.
So yeah, I guess in this second half, we're going to kick it off with talking about common childhood infections. So what are some common infections that we see in children, kind of based on their age group as well? So during which ages would we find certain conditions more common?
Right, okay. So as we talked about the respiratory illnesses, so there's a kind of an age pattern to bronchiolitis, viral wheeze, and the asthma. So it could be the respiratory or coming down to like the GI tract problems, so diarrhea and vomiting. So it can kind of involves all the children from kind of a birth to a few months to kind of a, by the age they reach 16 years. And it's just involving loss of viruses as well, GI did that cause a problem with the viral gastroenteritis. The most common is norovirus, especially during the time of the winter. So you have got the vomiting bug, most probably because of the norovirus. Again, the management is symptomatic, so you just need to make sure that even if your child is vomiting, they are getting the fluid replacement. So you can do the dialyte at home, or with the breastfeeding children, you can do the breastfeeds, or the formula-fed babies, you can do the formula feeds, depending upon the age of the child. And then the only problem comes into place when they're spiking quite high fever and having the blood in stools. So so obviously at that stage, it means that they need help in terms of antibiotics, because most of the time the blood in stools in the context of illnesses, diarrhea, vomiting, is because of the bacterial infection. Especially if you have travelled, from somewhere. So then in case of just keeping in mind the salmonella and, typhoid fever and things like that. So which means that you need to seek urgent medical attention, either via your GP or, to your hospital. So speak to one-on-one or book an appointment with your GP for them to be seen.
I see.
So apart from the GI tract, the problems and the other issues that tend to play, especially during the childhood, is the rashes and the fevers. So what we call as viral symptomatous fevers, which are quite common again. But there's some. So most of the viral infections, they tend to kind of present with the fever and the rash. So things like people will come across hand, foot, and mouth disease. So you will be having this kind of a characteristic rash around in your mouth, in the child's mouth, and in the palms and the soles of the feet. So no other rashes involves the palms and the soles. It's mostly the infective rash. So mostly it is the hand, foot, and mouth disease caused by the Coxsackie viruses. So then there could be other viruses that can come into play as well. So you have got a slap cheek syndrome. So this rash kind of tends to spread or we call it the fifth disease as well. So it tends to spread around the face, and then kind of this rash kind of goes around throughout their whole body. Your child will be spiking fever, but most of the time they look well in this sort of rash. So again, just kind of making sure they are having plenty of fluids, and then that should be enough, But if the fever is kind of prolonged, more than 5-6 days or so, or if the child is getting unwell, in terms of they are very sleepy, they are lethargic, and the fever is not settling down, or you're getting the infective rash, all over, then it's a sign to seek for urgent medical attention.
And we're helping them, we're supporting them with making sure that they're having enough fluids, things like that.
Exactly. And in terms of the ENT, ear, nose and throat infections, you can
very common.
very common in children. So again, those sort of cases, most of the time, if you're having the ear infection or the otitis media where there's discharge coming through the ear, or you're having kind of a child who's been very sore in the throat, they need to basically seen by a medical health professional, because at that point in time they might benefit from having some antibiotics. So scarlet fever is another thing with the tonsillitis that parents tend to kind of worry about. Again, the management is pretty much this straightforward. So just giving them the antibiotics. With any sort of bacterial infection, just need to keep in mind, even if you give the antibiotics, if they're deteriorating, if they're not getting better after being on the antibiotics as well, there's a concern that there is a spread of the bug or bacteria into the bloodstream. So what we named as bacteremia, or if it involves the multi-system, so the infection is kind of spreading and kind of playing up with your heart, playing up with your kidneys, and basically making you more poorly, then we worry about sepsis. So in this sort of cases, these children need to come to hospital straight away. So bring them to A&E. We'll see them. We'll give them first dose of their antibiotics, their fluids, and then we'll look after them.
Yeah, makes sense. All right, thank you. And now, I guess, moving away from infections and maybe more, or kind of similar, staying on the topic, I guess, when we talk about febrile kind of seizures. But we're going to be talking a bit about seizures and epilepsy, and kind of trying to break that down. So to start off with, what is a seizure? And then how does that kind of differ from epilepsy, or when does that become epilepsy?
Okay.
If it does become epilepsy.
If it does become epilepsy, yes. So seizure is basically a term that is being used for your electrical activity, abnormal electrical activity going on in the brain that manifests itself either in your change in behavior or in the movement disorder, or emotional, or they're kind of basically in their general neurological state, but we said that they're getting a bit more sleepy, or, so that's the electrical activity, abnormal electrical activity in the brain is driving all those things. Then we label it as a seizure. Okay. So most of the time people perceive it when it is electrical activity in the context of the movement disorder. So like jerky movements, shaky movements, involving either both arms or legs, or one arm or leg, along with eye movements, tongue biting, or incontinence. In a continent child. So that's how people tend to kind of perceive it. Or basically get worried about the seizure. So in the terms of let's just go to the febrile seizure itself. So febrile seizure is basically a terminology that is used when a child is having this activity, but in the context of the high fever. Okay. So as I said, children will, in their early childhood, will come across lots of infections, and that's how their immunity is going to build up.
Of course,
over time. But some of these children, when their temperature goes high, then it obviously causes abnormal electrical activity in the brain, and which kind of because of the changes in the thermoregulation of your body, and it can lead to the seizure itself. Okay. But what we tend to say is that if the seizure is kind of a short, if it is less than 15 minutes or so, if there is a kind of a movement of the whole body, not any particular part of the arms or legs, if it is, and it's not going to reoccur again in the first 24 hours with a good kind of a temperature control, then it's likely that it's not going to happen today. Most of the times it would not going to happen today. happen again, or if it happens again, it's not going to leave a life-limiting or lifelong effects on your brain.
Fine.
So the only thing is that if your child once had a febrile seizure with any sort of infection, if they're going to happen the next few years or so, you just need to be a little bit more vigilant in controlling their temperature.
Okay.
Just because once they had it, it puts them at high risk of having it again.
Okay.
But it doesn't mean that it's going to leave a lifelong kind of a problems inside your brain. So people don't need to worry about it. Okay. But sometimes it happens if in the context of the seizure have been very long, more than 15 minutes or so, or it's kind of reoccurring on the same day, even despite the fever control as well.
Yeah.
So it's not a pretty much straightforward febrile seizure, and then we kind of tend to worry about whether there's another phenomena going on behind this electrical activity that we need to explore a little bit more.
Fine. Okay. So that would kind of lead you to maybe investigate a bit further.
Definitely.
Fine.
Definitely.
Okay. And so just talking a bit more about seizures themselves, so we said that often they are perceived as kind of the movement changes that people might see, but there are other types of seizures, aren't there? Do you mind just touching a bit on those, the fact that they can be quite varied and broad?
They can be very varied and broad. So the seizure itself, they can be present, as I said, it can be your problem with the behavior itself. So you might find your child is kind of staring, glaring in the space, and then they're not responsive at that time. So that could be a form of a seizure as well. Again, there is investigations. You need to see a pediatrician with the experts in the neurology or a neurologist to kind of then, because they will do further testing like an EEG, to kind of prove it that is kind of absence sort of seizure, so going forward to the absence epilepsy. There could be myoclonic jerks that we tend to say, which is basically contractions of your muscles. So you're not having jerky movements of arms or legs, but a kind of subtle movements in your muscles all over, which we call as clonic kind of a picture. And that can come into play. But again, it will take a neurologist or the pediatrician with experts in neurology to then diagnosed as is it a juvenile myoclonic epilepsy that has been going on. So these things can kind of vary. And then in terms of the behavior, so some of the children, they tend to present as like laughing episodes, so uncontrolled laughter, and the subtle change in the behavior itself can make you think that there might be a seizure going on. But I think most of the time, when the first seizure presents, it's hardly because of change in the behavior itself. It would be associated with other signs and symptoms, so it could be kind of a myoclonic jerk. So a child would be kind of brushing their teeth, and all of a sudden in the washroom they have fall over. So these are the kind of things that can lead the parent to kind of be concerned about your child, to get it thoroughly investigated.
Fine. And as you said, you would need to go to kind of a paediatric neurologist or a neurologist to kind of look into that a bit further.
Definitely.
And in terms of moving on to epilepsy, what is epilepsy? How do we define epilepsy? I think is a good place to start.
Yes. So epilepsy itself is a name of a kind of a syndrome that involves the seizure activity. If it's a kind of a persistent, recurrent seizure activity that has been going on, associated with the abnormal electrical activity inside the brain, then it will be kind of labeled as epilepsy. But you need to kind of prove it with the investigations. So most of the time. So, in your EEG, when you go to see a pediatrician, they will request an EEG scan for you. So basically, which is a tracing of the electrical activity inside your brain, to kind of make sure and the electrophysiologist is going to interpret it, and that's how you would know what kind of epilepsy your child has got and what will be the right way of treating it, which medications. Then obviously, if the epilepsy, so most of the time the epilepsy is not associated with any sort of problems inside the brain structure itself, in terms of a lesion itself. But again, it will take pediatric neurologist to investigate it a little bit more. And then again, the treatment would vary in terms of there's other modes of treatment apart from the medicine that they can try for that. There's new interventions coming up, and there's surgery as well for the epilepsy.
Okay.
But again, this is a work in progress. Yeah.
Evolving area. But,
Yes.
Very interesting. And in terms of patients who have known epilepsy, for example, say if their child is having a seizure, what is kind of some of the advice we would say, or things that maybe we would find useful to have as clinicians once they come in through the door, in terms of how to manage it in the first few instances, I guess.
Yes. So for the parents, obviously, with the epilepsy, when you are having the movement disorder, so they are jerking, your arms and legs are moving, so you can't control it. So don't try to control it. Don't try to stop it. All you need to do is to put your child in a recovery position, so somewhere safe, somewhere there is no furniture around, and he or she, your child is not going to hit their head. That is the most important thing. And then just putting onto their side, just in case if they vomit or if they have got secretions coming through, they can kind of nicely come out and will not block their airway. I think if it is the first time that is happening to your child, you need to call 111, for the advice and support, or just call 999 so that the ambulance can arrive at the place and they can do a thorough check on your child. Most of the cases in children in pediatric age group, they will bring the child into the hospital, for which we need to observe them for a little longer.
Sure.
So that would be the first things. Now, if a child is known to have the seizures and the parents have been giving the medication, which we call as a rescue medication, then they will have a plan in place, tried by the pediatric neurologist, or the pediatricians with expertise in neurology. So they would be able to give them rescue medication first dose at that time. So usually it's about 5 minutes or so. And then just call for help, call for ambulance so they can arrive. Even if the seizures have terminated soon afterwards, then it's good for them to be there just in case, because of the medication, if they have any side effects.
We can monitor them.
They can monitor them. Yeah. Or if the child needs to come to the hospital, they can safely bring their child to the hospital.
Fine.
So it's in all the cases, especially, or if the seizures are going back to it. So if the seizures are going for long, then obviously they need to give some medication.
Yeah, so timing it is always a good...
Timing is very important. I know it can be hard as a parent.
Definitely. But I think not the first thought, is it? Let me bring out my stopwatch. But
exactly.
But it's helpful.
It's very helpful to us to kind of know. And then, but obviously, if you need to make sure that your child is safe first, and then timing it. And then I would say video it. So if you can video it, because especially if it is a first seizure, it will make it not very easy, but it will help us in kind of making the diagnosis. If we can see it, what was exactly happening.
What was happening,
So,
because sometimes it's hard to remember in the moment exactly what was going on and how long it was going for, especially when, say, if it is, let's say, the first time, or if it doesn't happen too common. I can imagine that parents might get overwhelmed with emotion. It might be a very distressing thing, but actually having the video evidence there means that it's easier for us to kind of see it directly, rather than having to ask the parents to try and remember what was going on when maybe, obviously it's very stressful. So that was a bit of a breakdown about febrile seizures. We talked about kind of what seizures are and epilepsy, and also kind of in the local environment in the NHS, there is a lot of support for these children who do have these conditions. They should have kind of regular follow-up and things like that. And like you said, a care plan with an outline of the management that they would do. So so that's really good. And we've got a little bit of time left, so I think we'll touch a bit about developmental delay since we have the time. And I guess I'll start off with asking you, what is developmental delay, and when is it often recognisable in the patient group that we kind of deal with?
So basically the development delays can be, so you have got 4 domains. That's how we kind of classify it, in terms of, or the expectation is from child to kind of achieve those milestones. So they are broadly classified into the gross motor, which means your kind of a neck hold, your sitting position, your standing, cruising, walking, running, jumping, going up and down the stairs. So that's your gross motor. And then there comes your fine motor and vision. So because fine motor skills are associated with your vision, so kind of making making sure that their vision is okay and then approaching. So if a child is kind of can't see properly and you're assessing their fine motor skills, well, you can't basically, because their vision is a problem rather than them achieving their milestones.
Got it. Okay.
So, the fine motor skills will be things like the grasp for a baby. So the kind of a hold that baby does with the hands. So we say palmar grasp, pincer grasps, or the way they have been handwriting when they grow up a bit, or holding the pencil for the very first time, and how they're scribbling on the piece of paper. And then we tend to classify the rest of the two domains are speech and language. So again, and hearing. So with speech and language, it's very important that your child is hearing first, and then you can assess their speech and language milestones. So when they started kind of cooing, making those small sounds, when they started babbling, when they said their first word, when they started having a bit of a vocabulary, all those sort of things. And then comes the social, so your social things will be if the child is having good eye contact, and then basically saying bye-bye, what age they have started doing that, or have got a stranger anxiety, or, all those sort of things come into play. So developmental A will be labelled at if your child is unable to achieve one or two of their milestones by the time they unable to achieve it by the 6 months. So let's say if a child is expected to do some milestones at the age of, let's say, a year, and the child has now gone to about 18 months,
without having achieved that.
Yes, or let's say maybe 2 years without achieving the basic milestones, so maybe 6 months or so is the definite one. So have gone without achieving the milestone that they were expected to achieve at 1 year, then it's a cause of concern. Or the example I can give you is, let's say if your child is expected to kind of a walk. So most of the children, they start walking around between the period of 12 to 18 months. So if your child has gone past 18 months, they are in their 20th month or 21st of, coming to a year, 2 years or so, and they are not walking. I would say if they have crossed 18 months and they are not walking, I think it's better to kind of get them checked and assessed by their GP. It again means it could be just they need another 1 month or so. But if it is any kind of a problem, in terms of their muscle problems, that's the most common that we tend to see, then it can be picked up, and then we can work on it, to improve it, to build up the strength, and then take it from there. So by the age of 6 months, I would say if they're not able to achieve that milestone, then it will be a developmental delay. Now, it can be one domain in which they can be delayed, or it can be multiple. So if it's more than one, we kind of tend to say it's a global developmental delay. So which involves basically the two major domains. So most of the time, like let's say if it is speech and language, and then they are having problems with their fine motor skills as well. So it will come under the domain of global developmental delay.
And then in terms of if patients do have global developmental delay or developmental delay in one of the domains, what kind of help is available in Luton for these types of patients and their parents as well?
So first of all, it's your health visitor is the first most important person. So you are having so all the babies who have been born, they are having their health visitor visits in the first few weeks. And then there's a 0 to 19 team works in Luton and Bedfordshire. So it tends to kind of it's available. So they might even not paying you the home visits. They can pay you the home visits, but even if they are not paying you the home visits, they can do the self-referral to them. Although they will try to get in contact with you when a child is going through their kind of periods of milestones. So they will contact you at about 1 year or so, or 18 months or so, just to check with you that you are okay, your baby is developing okay, and they might book a kind of a developmental review for the baby as well.
Okay.
And they will document everything on the Red Book. So
Fine.
all the babies who've been born in Luton and Dunstable, they will get their, or in Bedfordshire or in the UK, they'll get the Red Book.
Yeah.
So the Red Book is basically a passport to kind of know how the child is developing, going through each stage. And that Red Book is basically used by all the health providers. So from your GP to health visitors to your midwife, to your doctor, specialist doctor. Everybody is a way of communicating. So they will document, where the concerns were, and then they will do the appropriate referral.
Okay.
We have a very good team of the community paediatricians as well at Edmund Lobo Centre. There's a kind of, apart from community paediatricians, it involves other teams as well in terms of the occupational therapists and speech and language therapy. So they will be able to kind of guide you, and they will be able to provide you the support.
Fine. Okay.
So
there is a lot of support available.
Yeah. So it's just sometimes it's important for parents to kind of and your Red Book, it will say, what are the milestones that you were looking for in your child. So so let's say if again the walking is the most important step, or head control is the most important aspect of from a very young baby. So head control or the sitting with support, without support. Yeah. So, if at any point in time, if you're having concerns in any of the domain, even it could be speech and language, it's better to get it checked.
Yeah.
But it just doesn't mean that your child is delayed. Like in speech and language, for example, if you have got a bilingual sort of a family, this child will go to the nursery and they will not be speaking, the language, the English, basically, but they will be able to kind of speak and communicate in their own language very well. This means that there is no delay. It's just, they just need a little bit of more encouragement and time to kind of adjust. So I think there are lots of support available. And if it's your GP, should be the main primary contact as well. So if any point in time you're concerned about your child, book an appointment with your GP, and then they can do the referrals where needed be.
All right, and that brings us to the end of our show. Thank you so much, Dr. Aamna, I know it was such a whistle-stop tour of all of the conditions, but you broke them down very nicely. Really quickly, if there's one piece of advice you would give to anyone out there, what would it be?
So, to all the parents, I think I'm a parent as well. I think just go by your instinct. If you think your child is not well, just go by it. Just ask for help. You don't need to sit in, even if don't shy away from the fact that people are going to tell you you're being a worried mum or you're being a worried dad. That's okay. That's a nature's design for you, so you can protect your child. Just do that. Just follow your instinct and get the advice and support and help from the health professionals.
As and when you need it. I love that. Exactly.
Lovely.
Everyone advocate for yourself and what you think is going
Excellent.
on. But thank you so much for coming on today's show. It was really enjoyable, and I hope all of our listeners were able to take something from it. Thank you all so much for listening, and inshallah we'll see you again in another episode of the Health and Fitness Show. Assalamu alaikum wa rahmatullahi wa barakatuh.